Right, so our first case today will be presented by Dr. Michael Bushton, and it is a case of severe hypertension and nephrotic range proteinuria. And we're ready to start whenever you're ready.
Dr. Poril, Dr. Dominichak, Dr. Krush, thank you very much. Thank you very much for allowing me to present this case, which was taking place some 13 years ago. So this is an emergency department perspective. A 37-year-old man referred by family physician because of severe hypertension. This is not uncommon, where sometimes primary care physicians panic and refer patients for having high blood pressure, and usually these are quickly dismissed from the emergency room. He's usually healthy. For 6 months, he's treated for hypertension with atenolol 50 milligrams and had headaches, nausea, dizziness, left flank pains, no diarrhea or constipation, no melena, as you will see in a moment why it is of interest. He lost some 5 kilograms during this period. He has no family history of hypertension or renal disease. After digging a bit in his past history, it turns that some 20 years earlier, he had appendectomy, but the appendix wasn't inflamed. There was some non-specific ileocecal inflammation. Crohn's disease was suspected, but nothing really followed. He was admitted a decade later to surgery because of severe abdominal pain, and on CT there was some small bowel wall thickening and perhaps peritoneal fat stranding. He was treated with antibiotics and recovered and discharged and had nothing to do with it later. However, a few years later, he showed up in the emergency room with deep vein thrombosis. A well-cap for hypercoagulopathy was recommended but not undertaken. He was treated with enoxaparin and warfarin later, which he discontinued after a year. On examination, he was fully conscious, had no distress at all. His blood pressure was 190 over 126 with a pulse rate of 88, no respiratory distress, and he was quite lean. In the eye background, no alarming findings. He had clear lungs, normal heart sounds, no abdominal or flank tenderness, no organomegaly, no peripheral edema, normal peripheral pulses. Cuff blood pressure was 232 over 144, ruling potential coarctation of the aorta. He had no neurologic deficit, and no other finding, no skin rash, no purpura. Normal ECG, voltage criteria for left ventricular hypertrophy. However, at the age of 36, this is of some questionable meaning. However, his biochemistry turned severe hyponatremia, severe hypokalemia, normal creatinine, low albumin, 25 grams per liter, high cholesterol, and normal liver function tests. This certainly change the perception that he's just one of those patients who are referred because of physician's panic, which was indeed the real cause of his referral. He had normal CBC and red blood cell morphology. Urine sediment was normal, but however, stick positive for protein. This was confirmed also by sulfacyl salicylic acid. At that point, there is a dilemma. What would you think?
Right. So we're opening this to the audience. What's the next step? Yeah.
Yeah, and I still think that severe proteinuria and severe hypertension, in the absence of evident glomerulonephritis, is somewhat unusual.
Mm-hmm.
Yeah. You've got significant proteinuria.
We need a microphone. Microphone. There's only one.
There's only one, not two. They're in the wrong place.
And in very wrong places. Sorry for this. Okay. Will the camera see it?
Stepped up.
Yeah.
Well,
Yeah.
you've got significant proteinuria and significant hypertension. To the degree that they're linked, you probably need to ascertain what's going on at the level of the kidney. So in our current practice, I'm in Richmond, Virginia, biopsy would probably be quickly forthcoming as soon as the blood pressure has some measure of control so they don't bleed out when you stick the kidney. So I'd be attacking it diagnostically to see if there's something in the renal level that may be acting as a proximate cause of the hypertension, realizing this hypertension has not been really worked up from a neurohumoral point of view. It's highly likely that there's a renin element to this. So I think I'd go for the jugular earlier than later in the workup. And the usual serologies probably would be sent off in a diagnostic capacity, trying to ascertain what might be going on at the level of the kidney as well. So the rule-outs would be there. Biopsy would be shortly forthcoming, unless some miracle happened. And sometimes these miracles happen, but not often.
Well, you know, this happens in the land of miracles, but
Yes. Yeah. Yeah. Right. Another comment. Yeah.
I would also want to work up his hyponatremia and hypokalemia, which are pretty profound. So urine osmolality and electrolytes might be useful.
Yeah.
Thank you. I'm Vic Salver from Cambridge. Interesting case. Putting it simply, he's got nephrotic syndrome, but he's not edematous. But he's got two interesting things. He's hypertensive, which can be associated with secondary FFGS, which is a significant glomerulopathy. Also, he's got Crohn's disease, which is associated with kidney disease. You can get interstitial nephritis, which would produce blood in the urine. There are other renal pathologies that are associated with Crohn's. It's not clear if it's due to the treatment for Crohn's, like 5-ASA agents, or Crohn's per se. So a renal biopsy would certainly be important. His electrolytes are interesting. He's hyponatremic and hypokalemic with normal excretory function. Certainly, as mentioned, checking osmolarities, but checking renin and aldosterone to see if there's any clear cause of the hypokalemia, or checking the magnesium as well would be relevant. Thank you.
of course, but in our place, the renin and aldosterone take time. And as you can see, we are still in the emergency room. The low albumin and high cholesterol suggested it is a nephrotic syndrome.
Yeah.
Nephrotic syndrome is a hypercoagulable state. And however, it is usually state of intravascular volume depletion. And therefore, unless there is a glomerulonephritis, most typically lupus nephritis, these things don't go with such a severe hypertension. And at that time in the emergency room, someone thought that renal vein thrombosis could somehow link the massive proteinuria with acute or subacute hypertension.
Can you just ask, what treatment was he on?
Atenolol.
He was
Atenolol,
only on
yeah.
atenolol.
Hamrahi and Jefferson, Philadelphia. I agree with the majority of the comments made, but I would take a different approach. The question first is how to stabilize a patient coming in with such elevated blood pressure and electrolyte abnormality with some missing data. Just looking at your EKG and normal LVH, it tells me that despite the diagnosis of hypertension and being on atenolol, this advanced or significantly elevated blood pressure is something which most probably is acute on relatively seen stable hypertension from the past. Otherwise, he would not have a relatively seen normal EKG. The second thing is, what is the bicarbonate of the patient? What is the serum osmolality of this patient? We need some urine protein ratio, urine protein creatinine ratio, albumin to creatinine ratio. That would be the second phase of basically workup. This patient definitely needs a significant workup. We have to see if the hypokalemia is related to hyponatremia versus two different etiologies. Does this patient have, by chance, a plasma cell dyscrasia giving us a significantly abnormal or pseudo-hyponatremia? I think there are different things that we have to separate first, but key thing is to stabilize the patient.
Okay, there is a question in
Věra Čertíková, Prague, Czech Republic. I'm a clinical nephrologist, and I would strongly disagree that this patient should first have renal biopsy and things like that. Because first, you cannot do renal biopsy in someone who has high blood pressure of this. And it would take at least 1 week to safely load that down. He has no critical organ damage at this moment, so his blood pressure should be downregulated stepwise, first thing. The second is that maybe the proteinuria can decrease after his blood pressure goes down, and I would say that it's not sure that he has no glomerulonephritis. There are glomerulonephritides that have no changes in sediment, and they have only nephrotic syndrome. So this can still be glomerulonephritis. But I would ask whether he was taking atenolol when his heart rate was 88 with such high blood pressure. High blood pressure should decrease heart rate, and when you give atenolol, it should go down. So the first thing is to decrease somehow his blood pressure, because this is really dangerous, and the workup should be first really the minerals and things like that, but not renal biopsy.
We also didn't think at that time a renal biopsy would be in place. And I just want to remind you, it's still in the emergency room. And however, given the thinking that renal vein thrombosis may somehow link the nephrotic syndrome with the severe hypertension, renal ultrasound with venous phase Doppler was done. Didn't show any venous thrombosis. However, it shows a discrepancy between the size of the kidneys. The left kidney was 8.5 centimeters, was hyperechogenic, and the right kidney was 12.5 centimeters, with the resistance index on the left was high and on the right was normal, suggesting that
You might have renal stenosis.
Right, so there is a queue at this microphone, and they all want to tell you what they suggest. Please.
Sorry, Ana Oliveras from Barcelona, Spain. Before the ultrasound results, I wanted about this potassium so low. Because I think that the patient has really a nephrotic syndrome, almost a biological nephrotic syndrome, but we have no information about potassium in urine. So you must know before of other things, I think, if the potassium in urine is low or is high. And because this patient has had 2 previous abdominal confusing episodes and discomforts, so maybe the patient has something related with this hypokalemia that has nothing to do with the nephrotic syndrome, and we must thought about the possibility of to link these two things. So how was the potassium in urine? Do you have this data?
I think it was not low, but I don't. Unfortunately, I didn't write it down, and I don't remember it was not low.
Hi, Michael. So he's hyponatremic and he's hypokalemic. So you have to think about a hyperrenic state. So he probably has high renin. He may have renal stenosis. He may have 2 things together. I mean, I know he has a pathology related that's we'll probably find out on biopsy of his kidney that links together what was happening with his GI tract for many years. But this may be a case where you have 2 things. And he may have renal stenosis, and he also may have some other glomerulopathy.
Of course, these things are possible, but we were, how shall I say it, rigidly educated to look for Occam's razor and try to unify a diagnosis, as will turn out is not impossible.
Okay.
You've given a lot away.
Okay.
Please.
I'm Alex de la Sierra from Barcelona also. I don't have an explanation for some of the things that these patients has, but I was wondering why you were insisting in all this abdominal previous history. So considering that you are coming from Israel and the patient was probably Jew, you know, one of the possibilities of fault...
Actually not. The patient was an Arab.
Oh, so anyway, let me finish. Considering all these undiagnosed abdominal events that the patient has, and now it seems that he has also a nephrotic syndrome, I will consider the possibility of familial Mediterranean fever with complicated with renal amyloidosis promoting nephrotic syndrome. Anyway, I will need still to think a little bit more to explain the apparently tubulopathy or hormone dysregulation and the severe hypertension, considering that the patient has not a renal vein thrombosis, which was one of the original circumstances.
This is, of course, very important and good thinking and certainly relevant to the area. However, this guy missed 2 F's from the familial Mediterranean fever. He had no fever and no history of fever and no family history. So this is limited. It's not supportive. Let's put it this way. And the other thing was that usually when you have nephrotic syndrome with amyloidotic nephrotic syndrome, you tend to be hypotensive and not. And I think severe hypertension in this context, I think, is rarely described. Let's put it this way. So,
okay, we're ready to see more. We're ready to see more information.
So, at last, the physicians in the emergency department thought this patient deserves an admission.
Good. Good.
In the hospital, an opportunity arose to see the computed tomography he had done a few years earlier with his abdominal pain, and on this one, both kidneys were normal appearing with normal perfusion. The blood pressure when he had his deep vein thrombosis in the emergency room was normal. In the hospital, again, he had normal urinary sediment, and the albumin-creatinine ratio was 11.1. For those who are not used to see it in grams, this is still very high. This is very high. Because of the history of thrombotic events and the evidence of vascular compromise of the left kidney, we looked into some coagulation factors which were normal, with the exception of prolonged partial thromboplastin time. I'd like to... I'm waiting for suggestions.
Okay, there is silence. We've run out of
Okay,
suggestions.
so prolonged partial thromboplastin time may be suggestive of presence of lupus anticoagulant, which was indeed found. Antinuclear antibodies and ANCA was negative, so this was not supportive of lupus nephritis or, I don't know, periarteritis nodosa or something like that, which is also not associated with nephrotic syndrome usually. And as follows, antiphospholipid antibodies were elevated, confirming the presence of antiphospholipid syndrome. Now, retrospectively, it is possible that part of the abdominal pain and somewhat evidence of colitis he might have had, it's reasonable to speculate might have been thrombotic affairs. His supine plasma renin activity during atenolol that he was taking was extremely elevated. 15 nanograms per hour per milliliter, and aldosterone levels were also elevated, so we can say that he has secondary hyperaldosteronism. This certainly explains the hypokalemia. Computed tomography confirmed that the left kidney was small and had poor nephrographic effect, with a large, normally perfused right kidney, and nuclear studies suggested that the left kidney contributes less than 1% to the total renal function. So it seems that this patient has renovascular hypertension related to what appears to be occlusion of the left renal artery. You can see, I guess, the stump next to the aorta. You can see again that the left kidney is small, that it has, I hope you can see it, poor nephrographic filling. So treatment was begun with ramipril and spironolactone. His blood pressure came down, his headaches and dizziness dissipated. Sodium was still he was still hyponatremic, potassium normalized. Creatinine increased to 124 micromoles per liter, but came down again to baseline. This is, I guess, usual for such a immediate and rapid blood pressure reduction. Albumin creatinine ratio decreased dramatically from 11 to 3. He was given warfarin with the diagnosis of antiphospholipid syndrome and both a venous, at least one venous and one arterial event, so he is doomed for lifelong anticoagulation. He was discharged and shows in the hypertension clinic, blood pressure is very high, ACR was not performed though asked for, INR was normal, he insists that he takes his medications. I'm sure one or two of you have run into such a situation too. However, we have the habit of trusting our patients on one hand and suspecting them at the same time. So he was invited to return, and twice again he had the same thing. So fortunately he was not taking his warfarin. That protected him from cerebral hemorrhage with this horrendous blood pressure. So helplessly, we had readmitted him. On the second admission, his blood pressure was very high. He was again hyponatremic and hypokalemic. After ramipril was resumed, everything normalized, including a marked reduction of the albumin-creatinine ratio. Albumin rose from, I'd like to remind you, 25 grams per liter in a healthy-looking 36-year-old man and rose to 45 grams per liter. So if someone had doubts, it is the urine where his albumin was, it was in the urine where the albumin was leaking. And he had INR of 4, as should any patient with antiphospholipid syndrome be treated. So what now?
I'll go to your surgeons.
Right, we have the microphone there.
I have one question. I mean, his kidney was already shrunken at the time of the first admission, meaning that was probably not an acute event. I mean,
the history of hypertension was of 6 months. So it might have been longer. I can't tell.
Okay.
So this is a great case. And we used to see this kind of thing more frequently a couple of decades ago when we were doing renal vascular procedures for unilateral renal artery stenosis and other causes of this syndrome, which is a small, shrunken, non-functional kidney that's putting out a huge amount of renin. And that's causing a huge problem both in blood pressure elevation and electrolyte abnormalities and putting the patient at high risk. We had treated many of these patients after demonstration of noncompliance with unilateral nephrectomy. Since the kidney was non-functional, we really didn't think that we were losing very much, and that was highly successful in a number of cases. You've still got a problem, however. That doesn't take away the phospholipid syndrome and doesn't take away the need for prophylactic anticoagulation. But I think to manage this kind of recurrent hospitalization event, unilateral nephrectomy would be a consideration.
That's what we did. He was transferred to surgery. At the time of admission there, his blood pressure was nearly normal. Because of the demonstrated poor compliance and the lifelong need of anticoagulation, and if we entertain the thought of revascularization for that kidney, he would be stuck with Coumadin, with warfarin, and if stented, 2 antiplatelets agents. That's quite tricky for someone not all that compliant, if to put it mildly. And again, the contribution of the left kidney to the renal function was minimal. So, by the way, it was difficult to convince the surgeons. I've never run into such a case where I had such difficulty convincing a surgeon to perform surgery, but that probably deserves a different discussion. So a successful laparoscopic nephrectomy was done. Blood pressure came down without antihypertensive therapy. Electrolytes normalized, albumin remained normal, and ACR decreased even further. So now we have the pathology and some medial hyperplastic changes can be seen in the artery. Glomeruli seem reasonably preserved, some Bowman space enlargement. However, there is a substantial interstitial inflammation, as you can see, almost lymphatic follicle forming in the lower part of the of the figure. You can see it is reasonably consistent, and that again the glomeruli are. Oh, I missed something. Disappeared. Sorry. Silver staining showed minimal periglomerular fibrosis, but no basement membrane thickening. So the pathology report of the kidney was small, we knew that, had unremarkable vasculature and stump of the ureter. The capsule was easily removed, ruling out a variety of inflammatory diseases. Parenchymal slices revealed well-demarcated and separable cortex and medulla. On microscopy, there was interstitial fibrosis, remarkable tubular atrophy. Glomeruli were not sclerotic. There was some thickening of capillary walls and mesangial abundance. There was no clots within renal blood vessels. And the pathologist concluded it is consistent with chronic ischemia, which is what we found. I would like to, the patient didn't show up for the hypertension clinic. He claimed, I don't know if this was true, that because his blood pressure was normal, he could not get a referral. I want summary here, all the things that I think are pretty straightforward. However, hypokalemia is readily explained by hyperaldosteronism. However, the hyponatremia is not. Mm-hmm. And the hyponatremia was a very repeated finding. So there's no such a textbook feature of renovascular hypertension. However, angiotensin on one hand promotes sodium reabsorption, on the other hand it is dipsogenic. So this could be a possibility. On the osmolarities did not support a excess of ADH because he had diluted his urine very well. The sodium and FeNA were low. Probably he had the marked pressure natriuresis to account for that. However, these things have been described in scattered case reports. And a hyponatremic hypertensive syndrome was suggested here and there, I think mostly in pediatric cases. And one of them that was published in Hypertension maybe almost 2 decades ago, collected 39 such patients. And if you note that please note that the plasma renin activity and plasma aldosterone are on a logarithmic and not a linear scale. And you can see that in the shaded area were the people who had normal electrolytes, and in the open area were those who had hyponatremia, and they all had very high plasma renin activity. Plasma aldosterone was also high, but if we recollect that in primary hyperaldosteronism, if anything, there's a tendency for hypernatremia. Probably it's just a side effect of it's the secondary effect. However, what the hell has got nephrotic syndrome to do with renovascular hypertension? Proteinuria may happen when you have prolonged hypertension, but is usually mild, certainly not nephrotic range, and certainly not such massive. Usually when there is heavy proteinuria, it originates from the non-ischemic kidney, maybe Ang2 dependent, and is ameliorated by either revascularization, ACE inhibition, and so forth and so on. Blood pressure lowering per se can also do it. I'll skip and try to remind, I'll tell you, in the Jewish scholarly tradition, or rabbinical tradition, there is a saying that doesn't translate very well, but if you give author credit or cite properly, as if you brought salvation to the world. So let this be my contribution to salvation of our world. And Dr. Halimi Ribstein and Mimran from Montpellier in France have observed such patients with renovascular disease and compared and nephrotic and massive proteinuria, and compared them to those with glomerular diseases. And what they found is that after a captopril challenge, they those with the renovascular disease have a decrease in the GFR, had a decrease in the renal plasma flow, and a marked increase in plasma renin activity, indicating that, and all of those had occluded arteries. So it's not only renovascular hypertension. If you want, it's a more extreme variety of those. And others, also from France, probably prompted by the previous publication, looked in their database and found, I know that it's a not very handsome table, but what they found that what predicted massive proteinuria was not only renal artery occlusion, but also a big discrepancy between the two kidneys. In other words, an indication that the contralateral kidney was normal. This probably allowed for the massive proteinuria. As the contralateral kidney decreases, presumably because of the reduced function, also its ability to excrete protein is reduced. So I think in the interest of time,
you think
I might finish here.
We're coming to an end. So there is a comment from this microphone, and I have one too. Please, first the comment on the microphone.
Hi, I'm Varun Gaur from Indianapolis, Indiana. Just one comment. There have been case series published with antiphospholipid antibody syndrome associated with membranous nephropathy. So that should be kept in mind in future if a patient presents with proteinuria that's of nephrotic range in somebody who has antiphospholipid antibody syndrome.
Absolutely. There was a study published a few years ago in Current Rheumatology Reports, which shows a wide range of renal manifestation of antiphospholipid syndromes. Some of them could have been relevant, but I think there's no question what was the pathophysiology in our case.
Yeah, so my comment is that, of course, the renal artery stenosis is a disease that progresses. It's not in one moment. And of course, you did nephrectomy, but we don't know what's going to happen with this other kidney. And I have seen similar case where everybody was very happy and everything improved, but then things started going wrong in another kidney. And then, of course, the only treatment available is renal replacement therapy, and things are much more dramatic. So I spotted that he was 37 when he initially presented. So there are many, many years for this other kidney to also be affected. And I wonder if a patient like that, for me, needs to be observed and followed up in specialist clinic because things might go wrong.
Yes, but it didn't work out. He didn't show up for the clinic. As a matter of fact, 10 years follow-up by a phone call reported that everything is fine, but who knows, especially with a non-compliant subject. I would like to raise a question. Given the rather benign appearance of the nephrectomized kidney, maybe with a hindsight, would have it been better to try to revascularize it, reimplant it? I don't know.
We will never know.
No.
Of course, we will never know, but I think there is a suggestion coming there. Bob?
Not necessarily a suggestion, but I do want to go back to the very beginning of this case. This patient presented with a history of left flank pain, and that should have been a tip-off that, or could have been, that something was going on in the left kidney.
Acutely.
And now this patient presents with...
That's why renal vein thrombosis wasn't a thing.
Yeah, and so... But I think what was happening actually was a slowly progressive shut-off of intrarenal arcuate and intralobular artery flow as a result of this thrombotic process. And so that had been going on for a long time, I think, probably 6 months. And so then now you're left with a very small kidney that's non-functioning. And the highest renin secretion comes from that kind of kidney, a small kidney, but it still has to have some perfusion. And a lot of times in a patient with renal vascular disease from the main renal artery, that can occur by collateral vessels that come into play. And so you may have actually a total shutoff of flow by the main renal artery, but collateral circulation is still present. So you get these sky-high renin and aldosterone levels.
I think no question about it.
Okay, so I think we need to move to the next case. Last quick comment.
I would just like to ask one question. Do we know anything about his family history?
Yes, there's no relevant family history. Like with any type of history, it depends on the historian.
That's right. Yes, so on this very, very positive note, thank you very much. A fascinating case.